Hello and welcome back to the Psychiatry Clinical Cases. Today we're going to be talking about the answer to case number 3, which was called Dangerous Behaviors. If you don't know about the case, check it out. It's in the previous video. So today we're going to be talking about, or we'll discuss about what could be possibly wrong or right with our little girl called Adriana. So let's just kind of summarize what is the problem here in the previous case. Is that Adriana was a 4.5-year-old girl who presented with her adoptive parents. She was adopted from an Eastern European orphanage or institution, and they complained that she was excessively physically familiar with strangers. She would hug random people. She would walk off with strangers. She also had trouble regulating proximity to other people. So either she was too close to strangers, too far away from her mother. She intrudes her classmates' play space. Also, she had a finding she was easily distressed and had a problem in soothing herself, in self-soothing or self-calming down. And finally, which didn't seem so important, but something we need to take note of, is that she had growth parameter abnormalities. First of all, as she was early on adopted, she was small for her age, and then as she was adopted and she was given, the care and everything, she gained weight. However, her head circumference still remained small under the 5th percentile. This is something we should also keep in mind. So is her behavior normal? Is it just a outgoing, friendly child, and we shouldn't pathologize such behavior, or is this abnormal? Let's go to the normal developmental growth curve, or the timeline. At the age of 2 weeks, a newborn, or they found that the newborn prefers the human face more than any other object. As they grow on to the 4th week of life, there is a preference for the mother's face compared to any other face. Growing up to 2 months, the infant begins to make eye contact, with people who look at him or her. At the age of 3 to 4 months, the child or the infant begins to recognize faces, and they develop a very interesting and quite a delightful thing called the indiscriminate social smile. And this is basically a smile that the child presents whenever anybody looks at the baby. If you start to hello, and you try to wave, and you try to coo them, and the little things that people do to get the attention of a baby, and the baby smiles at you. So they develop this indiscriminate social smile that is not selective. It's for everybody. It's for anyone. But as they grow up from the 6th to the 9th months, they begin to get selective. They become selectively responsive, selectively close to people. So, for example, they become more responsive to mother, to caregivers, to family, but less responsive to strangers, to people in the outside society. And they begin to develop something called a frank reticence in presence of strangers at the age of 8 to 9 months. Reticence is a very important word used in the social development of children, and reticence means being reserved, being inhibited. So basically, the child, when there is a stranger in the room or a stranger approaching them, they become inhibited, they become reserved, they become shy, they kind of withdraw. They don't run towards the stranger, but rather retract away. And they develop 2 sorts of anxieties at that age group. First of all, they develop a sort of separation anxiety, and they develop a stranger anxiety. The separation anxiety is basically the stress or anxiety that is experienced whenever the caregiver, whether that be the mother or whoever's taking care of the baby, leaves the room or leaves the visual field of the child, and the child cries and seeks for their mother. As for stranger anxiety, and this is part of normal development, that whenever a child or unfamiliar human is near the child, the children become distressed or especially in the absence of the caregiver. If the mother is there and there's a stranger and the mother is kind of reassuring the child, it's like, it's okay, this is your uncle, it's fine, the stranger response might not be so high compared to a pure stranger in the absence of a caregiver. So separation anxiety and stranger anxiety are normal parts of development. Only when they are too much or they're too little, that is when it becomes maladaptive and potentially dangerous for the child. For example, a child who has extreme separation anxiety, so a child that it completely cannot function, cannot do anything, cannot explore in the absence of their mother, this really restricts their emotional regulation. This restricts how they learn. So the child becomes so preoccupied with their mother that they can't do anything else in her absence, and that is pathological. That's a type of insecure attachment. But a child that has no separation anxiety, so the mother leaves the room and the child is absolutely unaffected by that, that is also a type of insecure attachment. Okay, and that reflects a certain pattern of caregiving that is characterized by neglect. Stranger anxiety is the same story. Too much stranger anxiety, too little stranger anxiety. In Adriana's case, it seems to be that she has a very profound and very obvious lack of separation and stranger anxiety. And research has been done on many, many children who show these signs, that they just don't seem to be afraid of strangers. They seem to be very outgoing, approachable, friendly. They might walk off with unfamiliar people. They're warm and they're loving and they hug random strangers. They found that this is abnormal behavior, and they found that this is usually found in children raised in impersonal institutions. Okay, impersonal institutions like orphanages, okay, or like foster homes that are, I don't think it's foster homes, rather than kind of foster houses in which they have like lots of kids in one place. And these children who are raised in impersonal institutions, and what that basically means is that, for example, the caregiver or the social worker or whoever's taking care of them does not give them any individualized attention. The child is not treated in a personal, emotional, responsive way. Rather, they're kind of neglected or left to their own kind of thing. And these children tend to respond to anyone who shows them affection. So a child that has been raised in a way or in an environment in which they're not getting responsive, caring, emotional stimulation at that critical age of 6 to 9 months, they actually don't develop the separation and stranger anxiety and become very familiar with unfamiliar people. So this actually indicates, and of course Adriana, in Adriana's case, she was adopted at the age of 2 and 5 months, 2 years and 5 months, from an Eastern European orphanage, so maybe in Romania or something. So it's most likely that Adriana was subjected to neglect or pathogenic care during her stay in the orphanage. We tend to find this correlation between children presenting with disinhibited social engagement and neglect. Okay, and it's not. I have to point out something. Not all children who've been raised in orphanages and institutions necessarily have to become socially or have attachment problems. Not all of them have to, but the children who do present with that issue, usually, or a high percentage of them, are children raised in neglectful, pathogenic places where they've been raised. Also, Adriana, as we talked about, presents as with inability to self-soothe herself. That's also a reflection of how she could be possibly have raised in a neglectful environment. So she's not been cared for enough in the orphanage that she was in. She was not soothed, she was not calmed, so she does not have the ability to calm her own self down and needs other people to calm her down. and she was small for her age and with the small head circumference, and that could reflect several things. And we have to, we have to be kind of balanced whenever we're looking at a case in psychiatry, is that we look at it from a psychological point of view. What could be the psychological reasons, but also what could be the biological or physical reasons for this. So, for example, we could think of, and especially in Adriana's case, of the possibility of prenatal malnutrition, prenatal toxicity. Her mother maybe have been abusing substances, or she's developed fetal alcohol syndrome. Prematurity is also a risk factor for children who present with particularly small and impulsive behavior. And genetic risk factors and malnutrition after she's been born and in the orphanage. And we call that, or one of the very obvious signs of a child that's been raised in a neglectful environment, both physically and emotionally, is something called the failure to thrive. Right. So Adriana, I hope that I've kind of clarified that her behavior is maladaptive, and it's a result of abnormal, or rather it's not her fault, of course. We're not going to say it's Adriana's fault, of course, but it is that during the critical period in which she was supposed to develop these milestones, she was not given that care. And so she developed abnormal, maladaptive behavior. So according to the DSM-5, they would classify her as something called the disinhibited social engagement disorder, or the DSED. So social engagement is how people engage in social situations, how they get on with other people. And disinhibited means that it's not reserved, it's not inhibited, it is not restricted or selective. It is indiscriminate, it is inappropriate, and it is potentially jeopardizing to the child's well-being. So according to the diagnostic criteria here, is basically what Adriana is she's a child who actively approaches and interacts with unfamiliar adults. So actively approaches, okay, and interacts with unfamiliar adults, and exhibits 2 of the following criteria. Reduced or absent reticence, as we said. Reticence here is the reserve, the inhibition, the shyness, and approaching unfamiliar adults. Overly familiar verbal or physical behavior. So, for example, Adriana would hug people who are standing in the supermarket, or would, sit on the laps of random strangers. Okay, so that's verbal or physical behavior. Diminished or absent checking back after venturing away. So, for example, the child is exploring someplace. She wouldn't keep her eye on her parent and look for her mom. She would just venture away without looking back, without checking anything. That's abnormal behavior. And the willingness to go off with an unfamiliar adult with minimal or no hesitation. Again, she could just walk off with a stranger or with a random family and not check back, should not feel afraid, not anything. That is maladaptive behavior. This could put her at great risk of kidnapping, of abuse, and we live in a society in which children are in a lot of danger to being abused. And the DSM actually puts in some effort to kind of explain why these children develop this behavior, and as we've already discussed, most of them is due to social neglect or deprivation in the form of a persistent lack of having basic emotional needs for comfort, stimulation, and affection met by caregivers. So basically, they are neglected, they're not given care, they're not given comfort, they're not given affection, so they're just left like that. And that could be one of the causes. Number 2, maybe they are in a caring environment, but they are repeatedly changing the primary caregiver. So the child doesn't have the chance to form a stable attachment to anybody. They keep moving from place to place, from home to home. So they can't settle, they can't stabilize, they can't form a connection between one caregiver. And that also creates this problem. Or raising a child in an unusual setting. So for example, like we said, like an institution. With a high child to caregiver ratio. So for example, high child to caregiver ratio means that, for example, there's like 10 kids and 1 caregiver. How can the 1 caregiver give individualized attention and care and stimulation and comfort to each and every one of those kids? It's impossible. Okay, so that also raises a child who develops abnormal social engagements. Of course, to diagnose this condition, we usually need a child that is over the age of 9 months. And why did we say 9 months? Because, as you remember, that the development of such a condition, the development of this milestone of reticence and selective responsiveness is met by the 9th month of life. Okay. Before that, the child is indiscriminate, and that's true. After that, the child should be more reticent. Right. I just wanted to discuss actually a really interesting paper that I've been reading. This paper basically gets, it was set in the USA, and through the databases, they tried to get children who've been internationally adopted from different countries. So, for example, a child who's been adopted from South Korea, or a child who's been adopted from China or East Europe, like, for example, Romania. And they tried to follow up these children and see to what percentage or to what degree did they exhibit social disengagement, inhibited social engagement, and basically abnormal attachment. And as we already said before, not all kids who have been adopted or institutionalized before develop that. Not all of them, but most of them do. A large percentage of them do. And they found that also that this behavior kind of continues on into adolescence, so it is persistent in a way. However, its persistence into adulthood is still kind of not known. Okay, and that could mean, and possibly give us hope, that children who have been raised in such difficult, neglectful backgrounds have a chance to be rehabilitated, to have a chance to readapt, to become more able to deal with the society in a more appropriate, in a more safe way. The reason that we diagnose this, I don't think is just for a random diagnosis or for just to put labels on kids, but rather it's to be able to identify these kids who have been raised in vulnerable environments, and to sort of give them the extra attention and the extra care and extra support that they may need to help them recover and live a life that is safe, live a life that is more appropriate for them and for others. So to answer the question that I posed in the last video, are we pathologizing outgoing, friendly behavior? The answer is no, because we've looked at the normal development of a child, and we can see that there's a lot of variance in normal development. There's a lot of space to develop, and not all children have to develop in exactly the same way. But one of the main milestones of development is the development of the reticence, the social or stranger anxiety. It is developmentally atypical for a 4.5-year-old child to approach a stranger affectionately, to touch, walk and walk off with them, talk or walk off with them, especially without referencing their caregiver. This is maladaptive and potentially dangerous. We want to identify these children so we can give them the support they need, understand that they may have been raised in very difficult, neglectful backgrounds, and be able to support them, to be able to sort of, if possible, compensate them for what they've lost, not just to put labels on them, not to just to medicate them. I don't think that any of these kids actually do need medication, but we won't go into the treatment. But they do need a sort of psychological support and psychotherapy to help them adapt again. So that about sums up the answer to case number 3. I'm really glad that you are joining us. I really hope you will join us for the next couple of next cases coming ahead, and I will see you very, very soon. Thank you and goodbye.